Today we're going to talk about the psychiatric symptoms of dementia. In previous segments we've talked about the cognitive symptoms. However, the psychiatric symptoms are of equal importance. The objectives for today's segment include, number one, list common psychiatric symptoms seen in patients with dementia. Number two, describe hallucinations and delusions associated with dementing illnesses. Number three, describe the diagnosis and treatment of depression and dementia, a serious problem. And number four, explain common types of aggressive behavior and management strategies for individuals with dementia. Remember that the three most common neuropsychiatric disorders in the elderly are delirium, depression, as well as dementia. It is possible for a demented individual to have both delirium and depression. These can be very complicated patients. Let's briefly review what we know about dementia. We know that dementia is caused by the death of brain cells. On the left we see a normal brain, and on the right we see a shrunken, atrophic brain of a patient with Alzheimer's disease. When brain cells die, one of two things happen. Either the brain cells malfunction, or the function that is served by those neurons is lost. Today we're going to be talking about when those brain cells malfunction. It's also important to remember that dementia is a progressive disease. As we see here in the next slide of coronal sections through a normal, mildly demented, and severely demented brain, we see that there is progressive loss of nerve cells. This progressive loss of nerve cells creates an ongoing change in the symptoms, both cognitively and psychiatrically. Let's begin by talking about a few general principles in the management of psychiatric symptoms in Alzheimer's disease and other types of dementia. First of all, no psychiatric symptom is specific for a particular type of dementia. In other words, you can't say, well, the patient has hallucinations or delusions and therefore they have Alzheimer's disease or vascular dementia. As we talked about in an earlier segment, dementia can be caused by multiple different types of diseases. Any of the different types of dementia can cause any type of psychiatric symptom. Psychiatric symptoms vary from individual to individual. One patient may have hallucinations, another patient may have delusions, and a third patient may have no psychiatric manifestations at all. The third principle is that the intensity of psychiatric symptoms will vary on an hourly, daily, or weekly basis. What you may find is that a patient is mildly delusional in the morning, but by the time evening time comes around, the patient is severely disoriented and severely delusional. Or they may not have auditory hallucinations in the morning, but they do in the evening. And the last thing is that because this is a progressive disease, because the brains continue to die, psychiatric symptoms may improve over time. Sometimes simply doing nothing at all will result in the patient's hallucinations or delusions improving. Let's begin by talking about delirium in dementia. Delirium is a fairly common problem in patients with dementia, and there's a high probability that at some point in their illness, almost every patient with dementia will have a period of delirium. Remember, delirium is an abrupt onset confusional state caused by medications or medical problems. It's important in dementia because, first of all, it's common. Secondly, the symptoms may vary. And thirdly, that there is a standardized treatment for delirium, that is, figure out what the cause is and eliminate it. These things were reviewed previously in the neuropsychiatric segment of this series. It's important to remember that some patients with abrupt onset of hallucinations or delusions or abrupt onset of aggressive behavior may actually be delirious. It may not necessarily be part of the dementia, but a manifestation of their delirium. The complications of unrecognized delirium in dementia are significant. Patients oftentimes develop secondary medical problems. A confused, combative patient will stop eating, will have decreased fluid intake, and suffer all of the complications of dehydration, as well as weight loss from their poor oral intake. The confused, wandering, delirious, elderly dementia patient is more prone to hip fractures because they fall more. And all of these things can result in accelerated death for patients with dementia and delirium. if we're going to talk about psychiatric symptoms in patients with dementia, what are some predictors? How can we tell which patient may or may not develop psychiatric manifestations? Well, when it comes to Alzheimer's disease, the age of onset is sometimes predictive. That is, the earlier you get it, the more likely you are to have hallucinations, delusions, or some other psychiatric manifestation. Likewise, your premorbid psychiatric history is important. Patients with a past history of schizophrenia, manic depressive illness, or depression are at a higher risk for exacerbation of these illnesses with the onset of dementia. When we're looking at psychiatric disorders in dementia, they can be broken into three broad categories: disorders of thought, disorders of mood, and disorders of behavior. Let's begin by considering disorders of thought. When we consider abnormalities of thought in dementia, there are three broad types of symptoms. There are hallucinations, delusions, and paranoia. Paranoia refers to a pervasive suspiciousness that sometimes exists in patients with dementia. I'm not going to talk about it much in this segment because isolated paranoia is not as common as paranoia in the setting of other psychiatric problems. But paranoia can be treated with antipsychotic medications. But let's focus on the more common symptoms, which are hallucinations and delusions. Hallucinations are important in dementia because they're common. About 25% of patients with dementia, especially Alzheimer's disease, will develop hallucinations in the course of their illness. They are most commonly auditory or visual. Remember, a hallucination can exist in any sensory modality, but really when you're talking about hallucinations associated with dementia, you're usually talking about either auditory or visual hallucinations. They're increased in patients with sensory impairment. So patients who are blind or deaf or partially impaired are at higher risk for developing those hallucinations in the impaired sensory modality. These symptoms frequently occur in the middle stages of the disease, in years 3 to 5 of the dementia. What is the biological substrate for these symptoms? Well, on the left side, you see a normal temporal lobe, and on the right side, you see a temporal lobe from an Alzheimer's disease. If you look here, as identified by the arrow, you see the auditory receptive cortex, which is undamaged in Alzheimer's disease. But if you look over here, you see the association cortex as depicted by the arrow, and you can see that it is markedly shrunken in comparison to the normal on the left. This damage to auditory association cortex can lead to misfiring of the neurons in that area, and that's what produces auditory hallucinations. Abnormalities in this part of the brain are also associated with schizophrenia. Why, interestingly enough, patients with schizophrenia also experience auditory hallucinations. So it is this temporal lobe damage that can lead to auditory hallucinations, but yet the patient's hearing is not impaired. The next depicts the early, mid, and late stages of dementia as seen in brains from a patient with mild, moderate, and severe dementia. Notice how the temporal lobes are progressively shrunken. This means that in the end stage, oftentimes the patients do not acknowledge or manifest hallucinations because the damage is so severe that they are no longer identifiable. Consequently, hallucinations are more common in the middle stages of the disease. Likewise, visual hallucinations also occur. In the next slide, what we see on top is the brain of a normal individual through the occipital lobe. Below, we see the atrophy in ventriculomegaly as seen in Alzheimer's disease. This results from injury to the occipital cortices that store visual information. When these neuronal regions fire off, when this association cortex tells you that you are seeing things, they are as real as if they are truly there. Patients with visual hallucinations will oftentimes see figures or faces or perhaps creatures. Sometimes the visual hallucinations are poorly formed. Again, as you see from left to right, there is continuous atrophy in a mild, moderate, and severely demented patient. So the patient may develop visual hallucinations as the disease progresses, but then in the end stage they may no longer report or respond to those types of stimuli. Auditory and visual hallucinations are common in patients with dementia, especially those with Alzheimer's disease, but also with vascular dementia and all of the other different types of dementia that we've talked about previously. What's the differential diagnosis of hallucinations in dementia? Well, delirium can cause people to begin to hallucinate, oftentimes in an abrupt manner. Patients who develop depression along with dementia can have hallucinations as part of their depression. In that case, the treatment of choice is to treat the depression. Sensory impairment can facilitate hallucinations. So patients with impaired vision, with cataracts, for instance, may develop visual hallucinations. And don't forget hypnagogic hallucinations. These are the hallucinations that occur as you're falling asleep at night. They aren't necessarily distressing, they don't indicate psychosis, and they don't need to be treated. What's the treatment of hallucinations in dementia? Well, first of all, you need to maximize sensory function. If they have hearing aids and glasses, put them on. Keep a low level of light on in the room at night so they won't misidentify sensory perceptions within their environment. If the hallucinations are not terribly distressing, simply reassuring the patient may be sufficient. Oftentimes the patients think that they're going crazy. And in fact, what they think of as, quotes, crazy and what they're experiencing are different things. So it is allowable to reassure a patient who's experiencing hallucinations that no, they're not going crazy, that their brain is just malfunctioning, and that you'll get through this together. On the other hand, patients who are significantly distressed by hallucinations may require antipsychotic medications. Standard neuroleptic agents, such as Haldol or Narvane, usually are sufficient to either quiet the symptomology of the hallucinations or to eliminate them altogether. What are some indications for antipsychotic therapy for hallucinations? First, patient distress. There are some hallucinations that don't bother patients, and if they're not bothering the patients, and if the patient isn't acting on the hallucination, then they shouldn't bother you. You just need to recognize these symptoms for what they are, which is parts of their dying brain misfiring. On the other hand, if the patient seems severely distressed, then treating them is the humane thing to do. If the patient begins to flee the home because, for instance, they see a dead relative that terrorizes them, or an animal, if they hear voices saying to them things that could be harmful, such as command auditory hallucinations, ordering them to harm people, then they need to be treated. Or if the hallucinations are of such severity that they cause the patient to be agitated and pose a threat of safety to the caregiver, then again they need to be treated, usually with an antipsychotic medication. Let's move on to delusions then. A delusion is a fixed false belief with no basis in fact. About 25 to 40% of patients with dementia, all types of dementia in fact, develop delusions. In Alzheimer's disease, as well as vascular dementia, they're common in the middle stages of the disease. And delusions can be very distressing to caregivers. There is no specific neuropathology for delusions. Delusions are really a manifestation of global intellectual malfunction. On the left you see a normal brain, on the right you see a brain of a patient with Alzheimer's disease. Note how reduced in volume it is. This type of global neuronal damage and death frequently leads to sophisticated abnormalities of cognitive function, like delusions, false beliefs. What are some common types of delusions that you might see in your patients? Well, the four that you will frequently see are delusions about life circumstances, delusions of stealing, infidelity, and abuse. What's a delusion about a life circumstance? Well, for instance, this is the patient who tells you that this isn't their house, that their house is somewhere else, or this isn't their room, or that this isn't necessarily their family. Oftentimes, the family is tempted to take them to their ancestral home, thinking that they will feel better. when in fact they don't. Oftentimes they just simply become more agitated because you've changed their surroundings. So delusions of life circumstances are fairly common. Delusions about stealing. How many times will an Alzheimer patient report, they stole my money? My daughter or my son, who is the caregiver, is taking money out of my wallet at night. What's really happening, of course, is the patient is hiding their money or putting it somewhere because they're suspicious of their family. And then, since they're amnestic, they can't remember where they left the money. And as patients with dementia oftentimes do, they put 2 and 2 together and came up with 5. Since they had the money and they've lost the money, somebody must have stolen the money, and therefore it is the fault of their caregiver. Or they may blame it on their roommate in the nursing home, or they may blame it on the staff in the nursing home. Delusions of stealing are fairly common. Infidelity. This is the elderly gentleman who believes that his wife, who has had 2 hip replacements, is having a torrid romance with the 32-year-old individual who lives next door. Of course, the wife is 85. And oftentimes they will go around loudly announcing this fact. Delusions of infidelity are fairly common in dementia. Delusions of abuse can also be troubling, both to the family caregiver as well as to the professional staff who cares for an individual in a nursing home. This is an elderly Alzheimer victim residing in a nursing home who claims that, quotes, last night they beat the hell out of him. Of course, what happened was that he got up in the middle of the night and began to roam around. They carried him back to his bed, but before they did that, he tripped in the bathroom and now he has a bruise on himself. Of course, the family arrives the next morning and the patient is claiming that he was beaten and now he has bruises. The family is unsure what to do. If they file a complaint, the nursing home may ask them to take the patient out. The nursing home, of course, is embarrassed by all of this because they don't want anybody thinking that they're abusing their elderly patients. The same charge can be made against family caregivers. This is a very distressing symptom, both to the family, the patient, and also to the professional staff who's providing them care. What's the differential diagnosis of delusions? Well, first of all, delirium. If a patient who was with dementia was previously reasonably stable, and now all of a sudden they're making false accusations, you have to begin to wonder whether or not they might have become acutely delirious. Patients with depression can also develop delusions, especially negativistic delusions. This is the elderly Alzheimer patient who tells you that they cannot eat because their food pipe, their esophagus, is no longer functioning properly, or that they are convinced that their intestines are no longer working properly. Delusions can occur in depression. Simple cognitive dysfunction, misinterpretation of the environment, can cause patients to make accusations that aren't true. And finally, of course, some accusations may be correct, and that must always be taken into account. Sometimes patients are abused by frustrated, exhausted family caregivers. Sometimes patients are abused in nursing homes. Any accusation must be carefully examined. Staff should look for physical evidence that something actually occurred. But it must always be understood that patients with dementia do develop delusions. That's why it's very important, especially for nursing homes, to educate family caregivers about the symptoms of delusions in patients with dementia. That way they'll know that at some point these patients may actually make false accusations, either about the staff or about the family. What are some management strategies for delusions with dementia? Well, when that elderly individual walks up to you and insists that their family has them incarcerated in this nursing home, don't try to argue with them or convince them that they're wrong. That's a failed strategy. Distract them, take them over to the window, show them the garden. Get them involved with recreational activities. Reassure them. Tell them that everything will be okay and that tomorrow that you will consider some of the problems that they see with being, quotes, locked up. That isn't to say that you should feed into their delusions or reinforce them, but rather to try to distract them off the idea. When all else fails, for instance, if the patient attempts to flee the nursing home because he's convinced that it's the jail and that his family's got him locked up there to keep his money, then antipsychotic medications may be indicated. We'll talk a little bit later in this program about the use of antipsychotics for psychiatric manifestations in patients with dementia. Let's move on, however, to disorders of mood. We're going to speak mostly about depression. However, patients with dementia also frequently manifest anxiety and elation. The treatment of anxiety in patients with dementia is difficult because most anti-anxiety medications cause increased confusion. Elation likewise is difficult to treat, but fortunately it's relatively uncommon. Anxiety is oftentimes seen in delusional patients, in psychotic patients, and in depressed patients. So let's talk a little bit about depression in dementia. First of all, why do patients with dementia develop depression? Well, as we talked about in an earlier segment, depression results from damage to brainstem neurons that produce catecholamines, norepinephrine and serotonin. In this figure, we see on the left a normal brainstem, and on the right, we see a brainstem of a patient with Alzheimer's disease. The damage of Alzheimer's disease is not limited to cortex, but also to brainstem nuclei. On the top, we see a normal pons that's halfway through the brainstem. Below, we see the shrunken atrophic pons from a patient with Alzheimer's disease. Brainstem injury results in dysfunction of catecholamines in the brains of patients with dementia, and this results in disorders of mood. As we see in this slide, on the left is a normal pons, and the arrow points to the locus ceruleus, this brown pigmented region immediately astride the fourth ventricle. On the right side, the arrow points to an area with no locus ceruleus, because the neurons in this region have died as a result of neurofibrillary degeneration seen in Alzheimer's disease. These neurons produce most of the norepinephrine that is used by the neocortex. Likewise, nerve cells in the midline and the raphe are also dying, and these are the cells that make serotonin. It is loss of norepinephrine and serotonin, we think, that contributes to the high rates of depression in patients with Alzheimer's disease and other types of dementia. What are the clinical manifestations of depression and dementia? Remember, the typical Alzheimer patient has difficulty remembering symptoms. They also have difficulty finding the words that they want to say. Therefore, doing a mental status examination on them can be quite a task. Some of the things that you can look for in a patient with dementia to determine whether or not they have depression is, first of all, whether or not they have stopped eating, whether or not they are refusing food. Secondly, whether or not they're losing weight. Of course, these can be caused by other things as well, but decreased PO intake and weight loss should make you suspicious that perhaps the patient has become depressed. Irritability. Not all depressed patients develop the sadness and the tearfulness. Sometimes the patients actually become angry as a result of the depression. Emotional lability, where sometimes they may seem okay, and other times they may seem tearful, even catastrophic. Psychomotor apathy or agitation. This is the Alzheimer patient who's doing reasonably well, could attend some recreational activities, went out on the weekends with their family, but now they can't seem to get out of bed. Now they seem to be nervous and agitated all the time. And finally, untreated depression leads to a fall in cognitive level. Oftentimes you will see a 2 or 3 point drop or more in the mini-mental status score in a patient who has depression on top of their dementia. What's a proper evaluation if you think that your patient with dementia may also have depression? Well, first of all, exclude delirium. We've talked about that previously. Secondly, make sure that the patient doesn't actually have an unrecognized medical problem, that they're not hypoxic, that they're not having angina or peptic ulcer disease, that they're not in kidney failure. Assess for chronic pain. Chronic pain can mimic depression in both the demented and the non-demented patient. Psychosis. It may be that the patient is severely delusional, paranoid, or hallucinating, and that is why they are withdrawn and afraid of eating. Some people quit eating because they think the food is poisoned. Or sensory deprivation. It may be that the patient lies in their bed in a dark room all the time, that their glasses are never put on their face and their hearing aid is never put in their ears. You need to try to maximize sensory input to even the depressed patients. What's the treatment of depression associated with dementia? Well, you can start with a serotonin reuptake inhibitor, drugs like Paxil, for instance. I usually start at 10 in the morning and 10 at noontime. Other serotonin reuptake inhibitors are equally effective, whether it be Prozac or Paxil or sertraline. They all work pretty much the same way. Nortriptyline is the only tricyclic antidepressant that is very effective and very safe in demented patients. Usually we start them at 30 milligrams a day. Give it to them at night so it will help them sleep, because many depressed patients have sleep problems, and then titrate their blood level into the 50 to 100 range. It's important, if you start with either the SSRI or with tricyclic, to give them at least 6 weeks on the antidepressant to determine whether or not it's going to be effective or not. Then there are other medications that can be used, and ECT, electroconvulsive therapy, can be used in patients with dementia and depression when the depression has caused significant deterioration and the patient has not responded to standard medications. There are some treatments that you want to avoid for depression in demented patients. Antidepressants with high anticholinergic activity, like Elavil, should be avoided. Benzodiazepines, drugs like Valium and Librium, should not be given to patients with depression and anxiety. It will only make them more confused. Avoid polypharmacy, two or three different antidepressants. Use one, try it at therapeutic doses for 6 weeks, and then move on to another drug. Insight-oriented psychotherapy is of no value in a patient with limited cognitive abilities. If you don't treat depression and dementia, you're going to have additional problems. That's why treating it is so important. For instance, you're going to have worsening of behavioral problems. You're going to have weight loss and all of its attendant complications. Many depressed, demented patients take to their bed, and then they begin to lose their ambulatory skills. But most importantly, it prolongs and worsens the suffering. So every patient with depression, whether they be demented or not, deserves an aggressive trial of psychopharmacological agents to see if you can improve their quality of life. Let's talk now a little bit about antipsychotic medications. Antipsychotic medications are the medications of choice for bothersome hallucinations and delusions. What are some basic guidelines for the use of antipsychotic medications? First of all, identify target symptoms. The nursing staff who cares for that patient or the family caregiver needs to know what you're trying to achieve with the medication before you start. Otherwise, you'll never know whether or not the medication is effective or not. Secondly, select the appropriate medication at an appropriate dose with appropriate timing. We have a tape out on the use of antipsychotic medications in the elderly, but I just want to remind you that there are two types of antipsychotic medications. There are the typical neuroleptics, drugs like Haldol, Mellaril, and Stelazine, and then there are the atypical neuroleptics, drugs like risperidone and olanzapine. When you're talking about the typical neuroleptics, there are two types. There are the high potency and the low potency. High potency medications have a high rate of extrapyramidal side effects. Low potency medications lower your eyelids and lower your blood pressure. So therefore, if you have a patient who's having trouble sleeping at night and seems to be agitated and needs to be quieted down, sometimes the use of a low-potency neuroleptic like Mellaril, 20 milligrams at HS, helps them to both sleep and to have less distress over their hallucinations or delusions. On the other hand, patients who don't need help sleeping and don't need to be sedated, but simply need blunting of their delusions or hallucinations, would benefit from a high-potency neuroleptic like Haldol or Navane. Typical starting dose, 0.5 milligrams. Try it for a couple weeks. If that doesn't work, bump them up to 1 milligram until you get to a sufficient dose that the patient's symptoms are no longer bothersome. Atypical neuroleptics such as risperidone and olanzapine can also be used, and their efficacy in psychotic symptoms associated with dementia is still being studied by clinicians. With any medication, it's important to start low and titrate upward. It's important to monitor side effects, and we're going to speak about those in just a second. and most importantly, assess the impact on your target symptoms. If you've had a patient on 3 or 4 milligrams of Navain or Haldol for 4 to 6 weeks and they're still hallucinating, then that medication may not be effective for the patient and it's time to move on to a different medicine, like for perhaps risperidone. When you're using neuroleptics, it's important to remember that they have significant side effect. This is reviewed in another tape, but let me briefly go through them. The 3 broad types of side effects of neuroleptics are Parkinsonism, akathisia, and tardive dyskinesia. Drug-induced Parkinsonism can be seen in both typical and atypical neuroleptics. The classic symptoms include stiffness, bradykinesia, difficulty arising, and some problems with ambulation. Of course, in your Alzheimer patient, it may increase your risk for falls. Akathisia, that inner sense of restlessness, the pacing, wandering, hopping up and down patient. These symptoms occur in approximately 40% of patients receiving neuroleptics. They're seen in both the typical and the atypical neuroleptics. Treatment of choice for akathisia includes reducing the dose, the use of beta blockers like Inderol, 20 or 30 milligrams twice a day, and if necessary, benzodiazepines. Tardive dyskinesia is the 3rd type of symptom that you'll see as a side effect. Reducing the dose or paradoxically increasing the dose can sometimes help with tardive dyskinesia. It's important for anybody who is prescribing neuroleptics in the elderly that they be thoroughly familiar with these 3 broad categories of side effects. The other thing that people need to be familiar with are the new OBRA regulations for the use of antipsychotic medications in nursing homes. These next couple of graphics demonstrate the lengthy lists of indications and contraindications for the use of antipsychotic medications in the nursing home. Here you see the list of acceptable diagnoses as defined by the federal government. The next is an unacceptable list of symptoms that can be used for antipsychotic medications. The important thing to remember from these lists is that the use of antipsychotics in nursing home patients requires careful documentation and adherence to the OBRA regulations. The OBRA guidelines and compliance with these regulations is covered in a subsequent tape in this series. What are some of the behavioral complications of dementia? Well, there is assaultive behavior, there is intrusive behavior, and then there is annoying behavior. Let's begin with assaultive behavior. Assaultive behavior can be divided into physical aggressiveness, hitting, punching, pushing, sexual aggressiveness. That's where there's inappropriate touching, grabbing, or actually overt sexual acts, and verbal or physical threats. What are the causes of this type of new behavior in patients with dementia? Well, in the top you see a frontal lobe from a normal individual. Down below you see a frontal lobe from a patient with Alzheimer's disease. Note the severe atrophy of those frontal lobes. It's so atrophic that there is marked ventriculomegaly, dilation of the ventricles. What do your frontal lobes do for you? Well, that's where social graces and self-control is programmed. All of us have impulses that need to be controlled. For instance, have you ever been standing in line at the movie theater and some fellow walks right up ahead of you, butts in line, and demands to have his ticket next? Doesn't it just kind of make you mad? Wouldn't you like to just walk up and biff him one on the back of the head and say, "Hey fella, go to the back of the line"? Well, you don't. And the reason that you don't is because you got frontal lobes which have been programmed that say to you, "Whoa, don't do that, jail time, that's assault." That's what your frontal lobes do for you. And when you erase those programs that have been put in there over years by your parents and society, what happens is that impulse control is lost. And it seems quite natural that when somebody annoys you or makes you angry, that you punch them, you push them, you kick them, or you knock them down. It's important to remember that frontal lobe damage is progressive. On the left, you see a normal frontal lobe. In the middle is a moderately demented, and the far right is a severely demented, severely atrophic segment. Patients with aggressive, hostile behavior may burn through those symptoms over time and become apathetic. What are some of the mechanisms of assault in dementia? Well, one demented patient can assault another demented patient, especially in the institutional setting. Bearing in mind the fact that 60% of patients in nursing homes are demented, at least every nursing home has several potentially assaultive demented patients. Some patients provoke assaults by other patients by grabbing, by screaming, by making unwanted advances on those patients. And of course, sometimes patients can be so frustrating, or through their aggressive action towards staff, sometimes staff can be aggressive towards the patients. What's the management of assaultive behavior in a demented patient? Well, first of all, define the behavior. It may be that that person who is knocking other patients down is actually trying to, quote, help by pulling them out of their wheelchair because they think there's something wrong. Distracting that patient and involving them in recreational activities is more appropriate than prescribing antipsychotic medications. Identify the cause. Some patients become assaultive because they're afraid. Some patients become assaultive because they are aphasic and don't understand what the staff is trying to do with them. In that case, the appropriate intervention is to use alternative communication skills to try to reassure the patient that everything is okay. On the other hand, there are some patients who are assaultive for no good reason, and those patients will need to be medicated. Next, you need to use behavioral management strategies. Figure out what's causing it, what is the stimulus for the aggression, and try to limit or eliminate that stimulus. And if all else fails, then you can reach into your black bag and start using medications with these patients. What's the pharmacological management of aggressive behavior? Well, the most commonly employed medication are the antipsychotics, drugs like Haldol, Navain, Mellarville, Risperidone. Actually, the literature assessing the usefulness of antipsychotics in aggressive behavior is equivocal. It's not clear whether these medicines really do help with that sort of impulsive, aggressive behavior. What does happen, however, is oftentimes the patients are made drowsy or so stiff from the Parkinsonism that they either don't care anymore, or when they take a swing at you, they're so stiff that their right hook isn't as snappy as it used to be. On the other hand, some medications help blunt impulsive behavior, such as Tegretol, valproic acid, or lithium. These medications are particularly helpful in that unpredictable, explosive patient. These medications should be used with great care because they have significant side effects, and their therapeutic blood levels should be monitored. If you're going to use them in therapeutic doses before you quit and go on to another medication. Serotonin reuptake inhibitors, drugs like Prozac or Paxil, they may also play some role in treating agitated, aggressive patients. Benzodiazepines, drugs like Valium and Ativan, are commonly used. However, their usefulness in aggression is unclear. It is helpful sometimes in the short run if you just need to acutely sedate a patient to give them a short half-life benzo like Ativan. However, bear in mind the fact that when they wake up, they're going to be more confused. Long-term benzo usage is probably not helpful in aggressive, impulsive behavior. Some patients, when they're put on benzodiazepines, actually become disinhibited and become more violent and more unpredictable. What about intrusive behavior? Symptoms like wandering or elopement, rummaging through other patients' room, or what I call directed incontinence. Directed incontinence is that patient who pees in the corner all the time. Urinating in the corner may be due to any number of symptoms. The patient may not remember where the bathroom is. The patient may not know how to get themselves undressed in a timely manner to go to the bathroom. Or it may simply be that the patient can no longer visually identify the bathroom as the bathroom, and the corner seems to be an acceptable place. These types of behaviors are usually not well treated with medications and generally respond to some sort of behavioral intervention. Wandering, for instance, usually is improved by things like recreational activity, as is the same with rummaging. Directed incontinence is improved with a toileting schedule so that the patient's bladder is emptied every couple of hours. Annoying behaviors include things like disrobing, repetitive questions, stealing, hoarding, or hiding, and shadowing. Shadowing is when the patient follows the caregiver all around the house. Although these are annoying behaviors, they generally do not respond to antipsychotic medications. They usually respond only to some type of behavioral or recreational intervention. These types of behaviors will be covered in greater depth when we talk about behavioral abnormalities and management of behavioral abnormalities in dementia. In conclusion, psychiatric symptoms are common in patients with dementia. Patients suffering from psychiatric manifestations such as hallucinations or delusions can be disruptive and threatening. Appropriate diagnosis is the first step, and then if an appropriate target symptom can be identified, antipsychotic medications or behavioral interventions will oftentimes improve the patient's symptoms and improve their quality of life.